Well, hello everyone. My name is Michel, and thank you very much for joining us. Today, I'm delighted to host Professor Sebastiaan Overeem to discuss the sleep challenges faced by people with Parkinson's and the potential solutions. I have personally come across a large number of people with Parkinson's who are sometimes sleeping no more than 3 hours a night. And frankly, this has also been my personal experience last year. The consequences of this are severe, as the lack of sleep impacts our ability to function physically and mentally, and of course makes our symptoms much worse. So Professor Overeem is a distinguished clinical somnologist and a sleep researcher renowned for his expertise in sleep medicine. He is particularly focused on the sleep issues associated to Parkinson's, and he was recommended to us by Professor Bas Bloem, with whom he works closely. Professor Overeem practices at the Center for Sleep Medicine in Kempenhaeghe in the Netherlands, a leading institution dedicated to diagnosing and treating sleep disorders. Before we start, as always, I would like to remind everyone that this session is for information and education purposes only. And if you are seeking medical advice, please make sure that you consult a medical professional. There will be time for questions at the end of the presentation. If you want to ask a question, please use the Q&A function at the bottom of your screen. And for those of you who don't know us yet, most of you will know us very well, but No Silver Bullet is managed by Mark Lambert and myself with the aim of sharing Parkinson's expertise. We aim to help you and frankly to motivate you to make informed choices on how to adapt your lifestyle to manage your symptoms and hopefully to slow down disease progression. As you know, we post the recordings of our webinars on YouTube and Spotify, and the details are available in the chat section at the bottom of your screen, as well as on our website, nosilverbullet4pd.com, nosilverbullet4pd.com. But let's come back to today's topic and to Professor Sebastiaan Overeem to discuss the sleep challenges faced by people with Parkinson's and hopefully the potential solutions. So Sebastiaan, the stage is yours.
Mm-hmm. Thank you very much. Well, the first step is to try to get something on screen. So please let me know if that works.
It's working perfectly fine.
Okay, excellent. Yeah, Michael, Mark, well, for starters, thank you very much for inviting me. It's basically, it's a bit of an honor. I mean, I'm very impressed what you guys have set up. So I hope I can do it a little bit of justice. It's the first time for me to do it in this kind of context. It's late in the evening up here. So, but I hope I can be of some insights. Yeah, thank you for the introduction. I'm indeed a sleep researcher. I'm not a Parkinson's disease specialist per se, but interested in sleep and the effects of sleep disorders on people's lives. And indeed, in my time in Nijmegen, I started to work with Bas Bloem and recognized from that moment on the very severe impact that sleep disorders can have in Parkinson's as well. And since then, I've been doing both research but also clinically work in hopefully make a bit of a contribution there. Yeah, you already mentioned it a bit quickly, but to recuperate in the lower of this slide, there's a lot of questions. You can ask every question you want, but individual medical advice is always difficult. And that will actually be also the end of my talk. Please do not only to help me out, but especially yourself out. If there's anything going on with your sleep, discuss it with your caregivers. I will see how much time it will take, but what I'd like to do is give you a little bit in general, few slides on sleep in general, because I'm fascinated by it. I think it's good to realize a little bit on how sleep works in the brain, because it helps to understand maybe a bit more what's going on in Parkinson's disease. A few things about general sleep medicine, how physicians working in sleep disorders look at sleep and sleep disorders. And again, a bit as a, let's say, preparation, and then spend some time on what is going on in Parkinson's. Not really extensively describing everything that can go on, but also talk a little bit into mechanisms, because that can not only help doctors, but also yourself to think about, hey, what could be a reason for if there's something going on in sleep. Then I will give a couple of examples with some general points of treatment, but again, as you will see, the spectrum is so broad, I cannot automatically cover everything. but I'm sure that things that I've missed in the talk will come up in the questions. It's a slide I often show in the beginning because, well, there's some cute animals, and then, well, actually you're already 1-0 in front of everybody. But it's interesting to think about sleep. It's a very peculiar behavior. We do it about 1/3 of our lives, and it's something that almost in the whole kingdom is found, from birds, mammals, fruit flies. There is actually no animal that has not a certain behavior that's classified as sleep. And I always say, if you are a predatory animal and you're running away from that lion the whole day, the stupidest thing to do is to lie down and close your eyes and be responsive to stimuli. And still, these animals do this as well. So apparently, sleep is important. And well, $1 million question still is, okay, what's the exact function of sleep? And a lot of research is still going on, and it's also, there's not one answer. It turns out that sleep is hugely important in a whole host of let's say, bodily functions. And part we learn about, if we learn about what happens in the brain during sleep, but also a lot is what happens if sleep is disturbed. One of the function the function of sleep is very, very clear is, for example, in memory formation. REM sleep, for example, has a role in sifting out, okay, what experiences need to be stored in your brain for a longer time, and what experience do you need to lose. It helps to keep up your daytime vigilance. It has influences on your immune system. There are all kinds of hormones, and certain hormones are specifically produced during certain sleep stages. Sleep has a very important role in the development of the brain when growing up. Your brain, and actually your body in general, produces all kinds of, let's say, waste products from metabolism, and during sleep these are cleared. So many lists, and on the right it's one of a folder that the American Academy of Sleep Medicine is actually putting forward to make the general audience more aware of the important role of sleep in a lot of different body functions. And as you already mentioned, there are a lot of consequences when either sleep is too short, curtailed, or disrupted by whatever reason. And there are short-term effects, for example, on mood, on concentration, on memory. If it's more severe, it can be daytime sleepiness. I will talk about it more, but people falling asleep actually unintentionally during the day. But it can also be more subtle, but not less important or even dangerous, when actually people are awake but not as vigilant as they should be. And if you look, and in large studies on a more higher level, it seems it's very clear that people with sleep disruption have reduced productivity, increased risk of road accidents, of accidents at work. And then even longer term, it has all kinds of bodily consequences. There's associations with sleep disruptions and obesity, with immune dysfunction, and also with a host actually of disorders. Diabetes, depression, several sleep disorders increase the chances of developing cardiovascular disease. There are clear links with dementia and sleep loss, and actually this list is growing. So sleep is important, well, if you sleep bad, I don't have to convince you of that, but still we work on it. The second thing I think that may not be as evident to some people, and let's say 100 years ago was also not very interesting to sleep, to researchers, brain researchers. For a long time it was thought that, okay, sleep is some kind of a passive state. Your brain shuts down a little bit, it's not very interesting, and in the morning it turns on again. And nothing could be farther from the truth. It is important to realize that sleep is a hugely complex process in the brain, where basically your whole brain is needed, and there are brain areas spread throughout the brain and the brain stem that are involved to generate sleep in a proper way. There are different sleep phases. You've heard about light sleep, deep sleep, REM sleep. These are all generated by different parts of the brain. These brain areas have also connections to each other, and they are even orchestrated again by other systems. So for example, all these sleep systems are also under the regulation of the biological clock, for example, and making day-night rhythms. And that also shows a little bit that sleep is also vulnerable to a large extent, because any dysfunction or damage to starters to these brain areas can affect sleep in a negative way. And so in this way, there's not only plenty of time for things to go wrong. I mean, you spend a third of your life asleep, but there are also plenty of reasons for things to go wrong. Again, sleep in the end is a vulnerable state. And that part explains that sleep disorders, even without Parkinson's, in sleep disorders in general, are very, very prevalent. If you count up all the different sleep disorders that are known, it starts to come to about 10% of the population. And then with these consequences, it's really, really huge. There's a lot of sleep disorders. Currently, over 80 are described. It's still a young field. We're still learning about sleep, and every now and then a new sleep disorder is described as well. And it's really a medical field still in transition, and it's growing and it's becoming more mature. Not for you of course to remember, but also to give you some insight in that spectrum of sleep disorders. There is an international classification, let's say the Bible of sleep medicine, where the different known sleep disorders are described, and those 85 that are currently known are let's say categorized in several parts, and that gives you also some insight in, let's say, the broad spectrum. There are several disorders where there's the primary problem is people having trouble falling asleep or staying asleep, waking up many times during the night or waking up too early. And these are the category of the insomnia disorders. You most likely have heard of sleep apnea, which is a specific breathing disorder during sleep, and there are several different ones. So this is a whole different category. There are some other disorders where falling asleep during the day unintentionally is the prime symptom, and where there are things going on in the areas of the brain that should keep you awake during the day. And these are called the disorders of hypersomnolence, and narcolepsy is an example of that. Disruptions of the biological clock fall under the spectrum of sleep medicine. And of course, for example, you have evening persons, you've got morning persons, but you got sometimes so extreme evening persons that actually they cannot function properly in society, and then we call it the circadian rhythm disorders. There's a whole group of disorders where everything that moves and behaves during sleep where it shouldn't is classified, the so-called parasomnias, and sleepwalking is one of them, and we will come to speak about REM sleep behavior disorders are that part. Sleep-related movement disorders like restless legs, and that are more simple disorders but repetitive, or more simple behavior, let's put it that way, and more repetitive, can be very disruptive to sleep, and often present also in Parkinson's disease. So again, it gives you a bit of a flavor of the broad field of sleep. And then sleep and Parkinson's, and in the last, well, let's say 20 years, more and more it's recognized that sleep is important in Parkinson's, and then as researchers and both as doctors, we sometimes feel, how do you say, very important that we now describe the importance of sleep, and like we discover it for the first time, and that's almost never the case. And if you read the very first description of Parkinson's disease by James Parkinson in 1817, he already basically knew it all. And there's actually several lines in this description of Parkinson's disease where it clearly says that sleep becomes disturbed in the course of the disease, and also that it can have different reasons. So the tremor can occur during sleep and disrupt it. There can be agitation and alarm, there can be parasomnias, etc. So in that way, nothing new under the sun, but now more and more it becomes part of clinical practice also by Parkinson neurologists to have attention to sleep and sleep problems. It's one thing that I always mention, because you start reading maybe on the internet and people are asked about how often do certain things occur and how often do sleep disorders occur in Parkinson's. And you see a lot of different numbers if you read, but and that's something also in research. You read, okay, one study found 60% or 70%. Several studies show that more than 90% of patients with Parkinson's disease also have a significant disruption of sleep. So whatever the number is, it's a lot. But those variation often comes with how research to define a certain problem. So if you ask someone with Parkinson's disease, okay, do you sleep less good than you did before you got Parkinson's disease? Almost everybody will answer in the affirmative. If you're a bit more strict and you say, no, okay, I only speak about the sleep disorder if a sleep study was done and we have a formal, proper diagnosis, then the prevalence is maybe a little bit lower, but it's still way over 50% of people. So it is, if you look at the non-motor symptoms of Parkinson's disease, besides the classical motor symptoms, sleep disorders really rank high up on the list. Another thing is that the sleep disorders that can occur in Parkinson's disease are really, really broad. And if you look at, let's say, broad description, there are a lot of reasons why people with Parkinson's may have trouble falling asleep, initiating sleep. There are a lot of different reasons why sleep is fragmented or people are waking up during the night. There's a host of movement disorders of sleep itself, or the movement disorder of Parkinson's is actually hindering sleep. And also daytime sleepiness is often not recognized as a sleep disorder in itself, is very often present. And to make matters worse, very often several of these sleep symptoms are together at the same time. And how to get a bit of let's say, structure in that. And what I often then tell is that it's good to realize how do these sleep disorders come about in the context of Parkinson's. And there are several, let's say, categories of mechanisms. And the first thing is that the disease process in the brain of Parkinson's is not only affecting, of course, the areas that affect movement. All these different sleep regions that are involved in regions of the brain that are involved in sleep can also be affected by the Parkinson's disease process. And depending on where that is, or the extent of the damage, this can directly lead to a disruption of sleep. But then you have got the motor symptoms, for example, of Parkinson's, and I will tell a bit more later on, can, let's say, have a secondary effect on sleep quality. A lot of medication used in Parkinson's disease, and of course, in several cases, it can actually improve sleep, but a lot of them have side effects in a negative way affecting sleep. So medication can be another factor. And then, as I already told you, that without Parkinson's, sleep disorders are very, very prevalent in the population. So, of course, someone with Parkinson's is not exempted for actually also developing an, in essence, unrelated sleep disorder occurring at the same time. So, the brain area damage, secondary effects of Parkinson's symptoms, medication effects, and let's say sleep disorders on their own. These are those mechanisms. And of course, these mechanisms often play a role together. And if you then give some examples, so one thing is normal, and I will show a bit more slides later on, but the so-called REM sleep behavior disorder, where normally the normal muscle weakness that prevents you from acting out your dreams is a very certain area in the lower brainstem, which can be very early on already affected by the Parkinson's process. But if the Parkinson's disease process affects those brain regions that are involved of starting up sleep or getting the brain to sleep, that it can result in insomnia. Restless legs, hallucinations are all other examples, and also in several cases sleepiness. There are brain areas that are very active to keep you awake during the day or during a webinar like this, and if that area is actually affected by the Parkinson's process, that can result in excessive sleepiness during the day. Tremor can occur at night and disrupt sleep. Stiffness, rigidity, and slow movements can affect having your posture in sleep and getting a good position. Leg cramps at night very often occur and of course can wake people up. And general things like pain, having to more often go to the toilet to void at night, have all direct effects on sleep. And a final thing, depression is very often occurring in Parkinson's disease, and it's a well-known factor to lead to insomnia. So all again a list of, let's say, Parkinson's symptoms that have or can have a negative effect on sleep. And then medication. It doesn't happen that often anymore, but in my sleep practice, especially 10 years ago when we started in our hospital, the Parkinson's sleep outpatient clinic, very often me as a simple sleep doctor, actually, I nudged the Parkinson's neurologist because I saw people where during the day they were detailedly, let's say, put on dopaminergic drugs in different times and doses, etc. And then at night, nothing, no dopaminergic control was taken whatsoever, and these people were stiff in bed and having a lot of troubles sleeping. And I just suggested maybe to take some action to get some dopaminergic controls. But also the side effects of dopaminergic, of course, like hyperkinesias, can actually be disrupted in sleep. Sertraline, one of the medications used for Parkinson's disease, is metabolized in the brain or in the body to amphetamine. And well, that's a very good way of keeping people awake. But if that happens at night, of course, it can lead to insomnia. And the final thing is, and especially when the dopamine agonist medications came on the market, one of the relatively important side effects that can occur is that they can actually induce sudden moments of sleepiness during the day, which in the beginning have been dubbed sleep attacks because they can come about sometimes very, very quickly. So again, a short overview, but the different effects that medication used in Parkinson's can affect in sleep. So how to approach it, and maybe a bit more from the medical perspective, but I think it's good also for you to realize, because maybe also you can nudge your caregiver if necessary as well. And if I talk to Parkinson's disease neurologists and nurses, etc., for me, I think the most important thing is that at least there is attention to sleep. So yes, there are so many aspects with Parkinson's that can affect life and are a topic of discussion in a consultation. But every now and then, I think a caregiver should probe a bit into sleep. And sometimes they find it scary because they say, okay, as soon as I ask about sleep, of course I get a lot of trouble. And now what do I do? But well, that's for later. But it's good to ask about, okay, how is your sleep going? Are there changes in your sleep quality? Can you stay awake, etc. There are some tools like questionnaires that can help with it, and then there are ways of further exploring it. And if a Parkinson's neurologist is not well versed in sleep itself, then there by now are so many somnologists around in the world that there's always someone with sleep expertise to get into consultation. And there's all kinds of tools. And even as a sleep doctor, if I could choose one tool, we very often use a sleep diary, a graphical sleep diary where people for a couple of weeks record when they go to sleep, or go to bed, when they get out of bed, and also subjectively mark when they thought they were awake or were asleep. And these are very, very informative tools, because you will see changes in the rhythm that maybe point to a problem with the biological clock. You see the pattern of insomnia. Is it in the beginning? Is it at night? Is it later in the night? Is it maybe something affected by someone's behavior? If you see someone going to bed very irregularly, for example. So it's a good tool. There's all kinds of Parkinson's disease sleep questionnaires. And to the right is the Parkinson's disease sleep scale, which it's important to realize, if you fill these in, it's not making a diagnosis immediately, but what it does is it screens in all those the different areas that sleep can be affected in a relatively quick way. So it's a very good way of screening, getting a first idea in which area maybe further needs to be explored. So these kinds of skills are very useful. And then in many cases, especially with severe sleep disruption, where the initial cause is not directly completely clear, a sleep recording is necessary. We call it a polysomnography. And of course, for some simple sleep disorders, these are tests that can be done at home and sometimes in some reduced montages. But in Parkinson's disease, we very often tend, at least in our hospital, to do it in the hospital so that there's nurses present, can be helped during the night. We often need to do extra measurements and electrodes. We want to really make sure if we put someone through the paces of such a recording that we can get the best outcome. And because of the complexity of the sleep disorders, you also need specific expertise actually to judge such a sleep recording. It's very seldom that it's, let's say, a simple sleep apnea diagnosis in someone with Parkinson's disease because of the complexity. And it's good to know why do we do it, and then I tell the doctors, okay, you need to do it. You need to first actually make a bit of a plan or an idea. Okay, which area do you want to look at, and to confirm it. Because of the complexity, we also do often these sleep recordings to make sure. Okay, did we get the only sleep disorder that we suspect, or are there additional sleep disruptors? Because if there are additional ones, you need to all take them into account when you want to treat, and also to judge the severity. I couldn't help. I will mention it because more and more people, of course, have all these fancy wearables and sleep trackers and Fitbits and Apple Watches that well, at least suggest they have a very detailed judgment of sleep and give you all kinds of graphs that even as a somnologist I sometimes have trouble interpreting. It's good to realize that these devices do not measure sleep directly. It's really a proxy, a surrogate, let's say, estimation of a bit of sleep based on heart rate variability, for example, which works okay if you're a healthy sleeper, but as soon as sleep is disrupted, they are not as good anymore. So be a bit careful with drawing conclusions from those. And actually, they can sometimes are not completely harmless. Actually, there's a recent new sleep disorder where actually people got so let's say nervous about their sleep quality because their smartwatch is actually giving them bad grades that actually they develop a sleep disorder. A very good way of having trouble falling asleep is actually start worrying about your sleep. So so this is a new area. I hope it's okay to take a couple of minutes more and shake your head if I'm going too long, Michael or Mark. But I will end with a few final examples that can happen, and also a bit of the approach that we think about. So insomnia, the general condition of trouble falling asleep or waking up, is something that in the general population is one of the most common sleep disorders. And there very often it has a psychological background with a stress factor that starts it up. But then through, let's say, conditioning mechanisms, the insomnia is actually perpetuating itself. And this can occur in Parkinson's disease, but very often there are additional factors that actually also perpetuate or cause the insomnia. So this insomnia is a starting point. There's a problem falling asleep or staying asleep, but then there needs to be a thinking process on what's going on. And well, very, very clearly, hyperkinesia, trouble actually translated into trouble turning around at night, is a very clear example on then it shows how important it is to find a comfortable sleep position, because as soon as it's not possible due to the hyperkinesia, then it shows how severely that can disrupt sleep. And that is not immediately something that automatically needs to be treated with medication. There, a physiotherapist and an ergotherapist can really help teaching people strategies to turn around in bed more easily, for example. But it's a very, very important factor. Dopaminergic control is now cleared in many studies, and for example, the rotigotine patch, for example, also a long-acting dopamine medication, in a lot of studies shown that it will increase sleep quality, and probably through many mechanisms, not only by making it easy to turn around in bed, but also it reduced actually the urgency to void during the night. It reduced nocturnal pain, so it has broad effects. More and more studies coming out now is actually that exercising is not only good in general for Parkinson's disease and also maybe for progression, but there have been studies that show actually that actually it has also exercise during the day a direct positive effect on nocturnal sleep quality, specifically in the Parkinson's population. I want to mention this one because these are those sleep hygiene, those general tips, 10 tips of good sleep, which you will find in every magazine. These are important things, of course, and it's very important for a healthy sleep and to keep a healthy sleep. But I sometimes are a bit annoyed that people with a severe sleep disorder are being told, okay, throw away that phone and don't watch it at television. And of course, that's not the solution there. For insomnia, if those other bodily functions are ruled out, there's actually preference to treat it without medication. There's very specific sleep therapy developed, cognitive behavioral therapy for insomnia, developed in the sleep field for years and years. And this is also should be the first line approach in Parkinson's as well. Sleepiness during the day, it's translated by people falling asleep unintentionally during the day, is something that should not be underestimated. It can happen a lot. It can have a severe influence on quality of life, on interactions, in relationships. It can be, of course, unsafe. And it can, again, have different reasons. It can be secondary to medication. It can be secondary to nocturnal sleep disruption. But it can also be a primary symptom of Parkinson's disease when these wake activating brain regions are affected. And then you should treat it by those causes to improve nocturnal sleep. Then if that all is done, actually a nap during the day can be very, very beneficial. Not too long, not too late in the afternoon, but very often as a sleep doctor, I advise that to people. And it helps with, let's say, distributing your energy. And then as sleep doctors, we are very well versed in medication that can actually help keep people more awake during the day. And I sometimes feel that these are a little bit underused also, for example, in the Parkinson's population. It can be very, very helpful. Light therapy is another one that can actually not only help with the circadian rhythm, but also keep you awake. And if I may, a couple of minutes at this because it's an important one, and it also it has actually for several reasons. One other sleep disorder that's very, very often occurring in Parkinson's as a result of the disease process is REM sleep behavior disorder. Normally during, as I told you, during REM sleep, during dream sleep, your muscles are completely paralyzed by the brain to stop people from acting out the dreams. And if this goes wrong, people keep their muscle tone during REM sleep and start acting out the dreams. It's very peculiar, but it's very often rather aggressive. There can be vocalization and swearing and shouting and kicking and punching. And it's not uncommon that people injure themselves or their bed partner. Very common in people with Parkinson's disease, but now it's something that's really in the spotlight because we as somnologists discovered the sleep disorder years ago, and we got people in our office with only this sleep disorder. And when these people were being followed, it turned out that in the majority of cases with this nocturnal sleep disorder, it's actually a prodromal first sign of people developing Parkinson's disease 5, 10, 15 years later. And this is, of course, now very important because there's hard work on new medication, maybe to slow down the disease process in Parkinson's disease. And if this is ever going to be on the market, then these patients with purely this sleep disorder, of course, are the most likely candidate. I've been talking too long, so I will probably end with this one. The point is, treatment of sleep disorders in Parkinson's disease is very, very important. Sometimes it's straightforward, getting better dopaminergic controls, but very often it's complex because of the different reasons. But it starts with attention to sleep by the caregiver, delving into it, at least look at the medication, and then make a precise sleep diagnosis. What is the mechanism that leads to, in this individual person, to the sleep disruption? And that's the entrance to treatment. It can be difficult, it can be trial and error, but don't give up. And if necessary, nudge your neurologist to maybe involve a sleep specialist. And it said in this commentary, it's time to do something about it. And well, we're trying, and luckily more and more treatment modalities for sleep disruption for Parkinson's come into practice. Thank you.
Sebastiaan, thank you very much for this introduction. I think it sets the stage in quite general terms, and now we're going to, yes, thank you very much. We're going to go through the questions. Just to our audience, we are quite a few people on the line today, more than 250. So I expect a lot of questions. We won't be able to answer all the questions. I think the chances of your question being asked will depend on, is it applicable to many people, or is it like your own case? And is it understandable, or is it so complex that I myself, I'm not a scientist, I'm not able to understand your question?
No,
so let's just get
our best together.
Let's get started. I think that you mentioned at some point breathing-related issues, and the first question we got actually from Phyllis, if I remember well. Let me just get back there. Yes, she basically suffers from cough that comes when lying down in bed at night. And she has either a shallow breathing, like a train puffing, and she's basically asking whether there are any solutions you would suggest for people who suffer from her specific condition.
Well, again, what I'm going to say is it depends on the diagnosis. So it's good to know the breathing disorders have there are different ones. What a lot of people know is called obstructive sleep apnea, where there is actually snoring, where it's actually the flutter of the upper airway, and if it collapses during sleep, you got breathing pauses. There are some signs that this may occur a bit more often in Parkinson's disease, but nevertheless, actually, it's very prevalent in general anyway. It can influence each other, but there are other breathing disorders. It can also be that there are pauses in breathing, not because there's obstruction in the throat, but there are less, let's say, breathing signals from the brain to the lungs and to the lung muscles. And this can sometimes occur in Parkinson's as well. And a final one I want to mention is, I actually, that's a good one to mention because I use the term Parkinson's disease, but this holds true for the spectrum of Parkinson's disorders. And in specific Parkinsonian symptom, the multiple system atrophy, there's another breathing issue. It's called, which is called nocturnal stridor, because actually sometimes the muscles around the vocal cords can actually stiffen up, and it starts first in sleep. And people making a very high-pitched sound during sleep, this kind of sound, and this can actually be really dangerous to breathing. So my point is, actually, there are several ones. And if sleep is disrupted and someone observes that there may be shallow breathing, etc., I mean, that's a good reason to show, okay, is this central sleep apnea? Is this obstruction? So it really depends on the cause. Yeah.
Understand.
Okay.
Thank you very much.
I'm kind of trying to be shorter with every question, but oh well. That's, yeah.
No worries. No, I think it's very clear.
Yeah.
I think that there are at least three different situations that you highlighted, and there probably are even more. So Phyllis probably needs to research this more with the sleep specialist.
There you go. And yeah, exactly. Yeah.
So a question from Marilyn that I'm sure will come up for many other people. She's asking about magnesium L-threonate for aiding sleep. And also the question that comes back a lot is melatonin. So let's just start maybe with magnesium L-threonate. There are different types of magnesium.
Yeah.
I personally take the threonate before sleeping.
Yeah.
What are your thoughts on that one, please?
Yeah. There are for sure some effects on magnesium on sleep. It's actually rather complex. It has a lot of different functions in the body. But there are some indications that it has affect some of the let's say the brain mechanism of sleep, but also very often, of course, that I mentioned the nocturnal leg cramps. And because of during sleep, the fluid shifts, salt balance also changes. So very often those painful cramps are actually occurring at night or in the morning.
Yes.
And that's actually a secondary effect of magnesium. So yeah, this could be in certain cases helpful. Yeah.
So sharing my personal experience for the leg cramps, I've been using magnesium butter. Massaging in my legs before going to bed. It is not 100% efficient, but it does help quite a bit in my case, but for everyone to experiment. Can I have your thoughts on melatonin? Because this is one that actually comes up quite a lot and is sometimes recommended away from sleep. just as
Yeah.
a supplement?
Yeah. Yeah, I can talk about an hour about it because we have a certain view on it. Melatonin is interesting. Melatonin is the brain's hormone of the biological clock to start with. So melatonin is produced in the brain and is actually the factor that actually prepares the brain during the course of the day towards the night to fall asleep. And even the lowest dose of melatonin that you take result in much higher levels of melatonin in the body than actually the naturally occurring one. We have been using it medically for a long time, especially when there are biological clock problems. And then you have to time it very well, actually a couple of hours before the intended sleep time. And that's rational. The point is, a bit in higher doses, it also makes you a little bit sleepy. So it can also be a bit more as a sleep initiating compound. But yeah, especially higher dose, it can actually build up in the body. It can sometimes actually, because of the timing, it could be wrong, actually induce some biological clock problems. So we're not very happy that some companies actually manage to call it a supplement instead of a medication. So that's why it's right everywhere. Final thing, it does also influence specific sleep stages. So for example, in that REM behavior disorder, those movements, it's known that high doses of melatonin actually can sometimes suppress this a bit. But that's something we would really like also to monitor over time. So,
Yes.
Yeah, well, maybe the final, maybe general in medicine or so let's say if you need every day to take something to fall asleep, it may be wise to first start to think about what's the reason. And maybe there could also be maybe some other solution that is more long term than that.
Understood.
Yeah, but again, on the other hand, if you're doing fine for a long time and don't have side effects and you can afford it, who am I to say not to? But that's the other side of the coin. That's of course also clear.
So I have two questions about natural remedies. Kathy is asking about valerian root, and I have often heard about valerian being helpful. And Maurice is asking about cherry juice. That one I had never heard of, but
no, yeah, okay. I mean, bananas, tryptophan, etc. I mean, yeah, natural remedies, of course. It's also a very broad thing. There are very, very toxic substances in nature, so it's not automatically that natural is better or good. And the second thing what I mentioned is that if you need to take something to fall asleep, for example, it's good to first think about what the underlying reason is before. So I don't want to advocate it as a general one thing fix all. But let's say if there is mild insomnia, which is no other medical reasons to be that are important, and someone has the experience that it actually helps these kind of compounds. Yeah.
Would you agree with the idea? Would you agree with the idea that actually, as long as we're talking about natural remedies, or for instance, low doses of melatonin, as long as we're not going to extreme, that we can work with our medical team to experiment safely?
Yeah, exactly. Yeah,
and see if it works.
Exactly. That is fine. Exactly. But don't get me wrong. But it's good to really think about, okay, why do I need this medication or this supplement? Could there be another reason that can maybe fixed or should be fixed before long term take that?
Yes. So Greg is mentioning how much help he got from meditation techniques.
Sure.
And he's asking your opinion on that, whether you think this is part of the weaponry we should have ready.
Yeah. The answer is yes. And that let's say if the insomnia in the specific case is not directly due to the pain, other medical disorders, then what very often happens is that insomnia can start by a live event or a stressful event or whatever, and then it gets the tendency to become chronic because let's say your brain gets used to the fact that you not fall asleep immediately all the time, but you lay awake for a while. And then very clearly, if you high stress levels before going to sleep, or let's say high activation level before going to sleep, for sure doesn't help. And in the spectrum of sleep therapy, is definitely for sure a place for relaxation techniques, in a very general way.
Yes.
Of course, there's all kinds of things that can help, including meditation. And yeah.
So at the opposite end of the spectrum, we have a question from Torben. It's quite a long question, but I think that if I'm trying to capture the essence of it, he started having Parkinson's symptoms 2 years ago after a couple of years of too much activity at work and being stressed emotionally as well. He feels it has brings his nervous system into overactivity, sympathetic overactivation, he calls it. And that creates tinnitus, arrhythmia, tension, low energy, etc., etc. And then it degenerates after several days and it gets even worse. So do you think this is true is it particularly true for people with Parkinson's, or are we just talking here of something which is more of a general situation that everyone would encounter?
I don't immediately recognize it as Parkinson's pure or specific, because these kind of mechanisms can for sure also occur outside of Parkinson's. But on the other hand, sure, you can understand these kind of conditions can actually mutually exacerbate each other. Yeah.
Yes. So Mary is talking about melatonin, and she has actually a slightly more specific question about melatonin. Does it help you to get to sleep, but not to stay asleep? So is it the question of, does it help you to sleep, or does it help you staying asleep during the night?
Yeah. It's for a large part also dose dependent, especially the higher doses stay longer. Several of the formulation are also long acting, and actually a certain long acting form of melatonin is actually also a formal medical drug for more stay asleep. So dose dependent, formulation dependent, but it starts, in essence, first thing first is initiating sleep.
Thank you very much. I will respond to Joe directly, because Joe is asking if there is any advice. Basically, Joe sleeps 3 hours sleep maximum per night and don't want pills, and asking if there are other options. Actually, I can let you answer this, but actually I'm hoping as well that through the questions from other people, Joe will see some suggestions of things that he or she could try safely. But I think that for someone sleeping 3 hours a night, as that person is describing, I guess that a sleep specialist would be recommended.
Yeah, for sure. I mean, so the first thing, that's very severe insomnia. Yes. And the second question, what's the underlying reason?
Yes.
Yeah.
Now, on that point, actually, it's a question of my own here. What is the underlying reason? Actually, well, we know we have Parkinson's, but I guess it's not just the answer. So what do you mean by what is the underlying?
Yeah. So for example, that's psychological insomnia mechanisms play a role. It could be organic sleep disorder, actually, that calls you sleep, it actually wakes you up, and then those mechanisms play a role. Maybe effects of Parkinson drugs, medication, which can have actually sleep disrupting effects.
I see.
You see what I mean?
I see. Yeah. Yes, exactly. So Kathy is asking a question that you have already answered, I think. She's asking about the sleep function on the Apple Watch. I think that you mentioned that already.
Yeah. So again, sleep is something of the brain. If you really want to measure it, you need to, for example, measure brain activity with that also sleep recordings. But during sleep, there are also changes in your heart rate, etc. And that is what we've known for a long time. And then the trick is, okay, if you measure a little bit of someone's heart rate, can you guess in which sleep stage someone is? And you can do that to a little extent, but especially if sleep is disrupted, it gets less reliable.
That's very useful.
And again, if it helps, if you're interested to see what's going on, if it's in accordance what you feel about your body, etc., for sure, then it's important. But both not automatically be completely assured. If you think, hey, there's something wrong with my sleep, but I would not go to a doctor because my watch says it's fine. But also on the other end, not automatically get restless if you get a bad grade, if you're feeling okay. Yeah.
So Jonathan has a question that is also burning my lips. He's asking about how effective is CBD for helping people with PD to sleep. And actually, I will add my own addition about THC.
Yeah, well, you can, well, you go ahead. But
okay. Well, look, I'm happy to answer that from a user perspective. So my experience is that I started with, I was diagnosed 5 years ago, and my first problems with sleep I could take care of through using melatonin. And that worked for a while, but last year my sleep started deteriorating to a point that melatonin was no longer enough. And I've been doing two things personally. I've been using Cinemet, so dopamine during the night, control release to get started, and then half of 50 milligrams or 25 milligrams during the night. That helps a bit. And then THC and CBD. I find that THC is more visibly helpful than CBD as far as I'm concerned. But I have a big word of caution. First of all, it is not legal in all the countries of the world, all the states, for instance, in the world. And the second thing, that THC in particular is very dangerous for people who have to get up at night and walk through the staircase, for instance. And the risk of fall is quite high. But it has helped me. And I'm very thankful, because this is the only solution I found as an alternative to addictive sleeping pills.
Yeah. Well, let's say for sure both actually CBD and THC, those are very, let's say, psychoactive substances, which also, let's say, on a theoretical basis and where they influence on the brain, can indeed influence sleep, can help sleep. Formal studies are slowly emerging. One important thing, besides the side effects, as you mentioned, we need to be careful about, is also the longer term effects. There are also some indications that longer term use actually, in certain circumstances, can actually have can also negatively influence sleep. So, I have a few patients that also, I've heard more sometimes that people start using it in the first time, a couple of weeks, very enthusiastic. I heard less cases where it stays for a longer time. But a lot of research, formal research going on now with these kind of substances. So,
Thank you very much for sharing the answer. It's the first time I'm answering the question myself. So Fred is referring to vivid dreams and nightmares. He has tried several drugs with his neurologist, but nothing helps. I don't know if you have any suggestions.
Well, vivid dreams and nightmares, that's already a little bit, those are, let's say, if you look very precise, a little bit different things. There are different ways. So there are also the spectrum of hallucination during the night. So, for example, in nightmares, people waking up with very clear dreams with a very emotional, negative connotation. There is quite some experience in the sleep fields of actually there are therapies for that to influence nightmares and the content of nightmares. And it's called IRT therapy, imaginary prescriptive therapy. But for example, also they can be brought about by actually several sleep disorders. So for example, people with that REM behavior disorder that start acting out their dreams. A lot of these people also notice that since they have these movements, that also the content of the dreams is actually become much more negative, for example. And actually sometimes treatment of that can also help. So there again, I'm sorry to say, but again, the fact that I tried several drugs, I understand, didn't help. Then it starts like, maybe to further tease it out, what is exactly the cause? Are these nightmares? Are these intensive dreams? Are these hallucinations? And that maybe that some sleep doctors specifically have some tricks up their sleeve. So,
Okay. Thank you very much for that, Sebastiaan. So Bob is asking about RBD. He's asking whether RBD is a binary condition. Do you have it or not? Or can there be degrees of RBD? Severe to less severe?
No, the answer is the latter. So if you measure the muscle activity with a sleep recording, you see muscle activity persisting. But the expression of that can vary a lot. It can actually within the subject. So maybe once, twice a week, something very big, and the other nights only a bit of talking, for example. And you have people that have it and have it very mild, not very dangerous, etc. And you have people that fall out of bed several times per week, hurt themselves, etc. So it's actually it's a big spectrum. Yeah.
Yes. Still on RBD, Peter is asking about Tanganil. I'm sure you have come across that vertigo. No, it's a vertigo drug sold in France. Tanganil.
Oh, that's absolutely because the brand names of medication.
Yes, there is actually I couldn't remember the scientific name of the component.
Yeah, it's acetyleucine.
That's right.
Yeah, it's used for vertigo, I think, if I'm.
Yes, but what happened recently, I think that actually there was a very small sample of 2 people who were given Tanganil, and there were unexpected, how should I describe that, repairs almost to their brains from a Parkinson standpoint. But the sample is very, very small, and there is a lot of hope.
Okay, not aware.
Okay,
but,
no problem.
I'm putting it on my list to take a look into. But I don't have experience, at least for sure, in the sleep context, no, personally. No.
So going back now to Pilar. Hello, Pilar. She's in New Zealand. Pilar is asking whether.
Sorry to interrupt, but
yes, go for it.
yeah, that's actually the that's the Tanganil. That's the word. Actually, there's some Dutch people and the German people were involved, and now I see that paper. Yeah, 2 case reports, very new. And again, clinically, I don't have experience with it, but it's especially in the REM sleep behavior disorder. Yeah. So,
yes.
Yeah.
But it was interesting because Tanganil is available in France over the counter. But the quantities, I mean, I'm telling everyone, please do not try it at home, or if you do, really take your own life in your own hands, because the problem with Tanganil is that the quantity you need to take is huge. I think you need to, so it's like a box every 3 days, if I remember well, for at least 6 months to see if there are differences. And we had Simon Stott talking to us from Cure Parkinson's in January. And I think there were some concerns about the impact on the mental impact it could have. Sorry.
Yeah.
So
I have to look up that study, but I think they gave a pretty high dose, if I'm correct. Yeah.
Yes. So Pilar was asking about brain waves during the day or during the night, and she's asking whether brain waves are responsible for, so whether motor or non-motor symptoms of PD are responsible for changing the brain waves during the day or a consequence of them. So are you aware of changing brain waves patterns recognized in PD?
I don't know exactly what is meant by brainwaves, because let's say if you call, let's say, the patterns in electrical activity in the brain, yes, they do change, but actually they are different when you're awake, they are different when you're asleep, and they're different in the different sleep stages. Yeah.
You see that. So, and we have actually someone anonymous asking, saying, first of all, very interesting, thank you. And asking how much sleep is enough and can diet help? We haven't really touched on that.
How much sleep is enough is a very good question. Again, nothing is easy to answer, but it's also important to realize a couple of things. It's very individual, the amount of sleep that the person needs. So that 7.5 hours that you read in the newspapers is an average. You have people that function pretty well with maybe 6.5 hours. Some people need 9. So there is spread. There are boundaries to that spread. So don't believe the people that say they function perfectly with 3 hours per night. So basically, how much does someone need to sleep? You need to sleep that kind of hours in order to function properly during the day. So actually, the readout is the effects during the day. And another thing is that if someone, for example, notices that during holidays, for example, they extend their sleep time significantly than normally, that is actually an indication that maybe that during those work hours they don't sleep enough. With age, with time, the total amount of sleep goes down a little bit. So it's not automatically that you need the same number of hours when you're 80 than you were before. Yeah.
As an addition to that question, do you have any comments on the amount of deep sleep and REM sleep that one would need?
Yeah.
Is it also depending on everyone, or is there?
No. Let's say there the percentage of time spent in REM sleep is about 20%, and that stays pretty constant with age. But for example, the percentage in the deepest sleep stages go down a little bit. But it's very important that it also varies from night to night. You need to estimate it very precisely, and it's not that you need a certain percentage, and it's also not that you need only one sleep stage. So that's one of the things with those watches that are somewhat troublesome, because oh, you don't have enough of sleep stage X, but that's not how it works. Good sleep is, let's say the interplay of these different phases in a pattern over the night of sufficient duration. So yeah.
Thank you very much. Sam is asking a question about something I have never heard about. She or he is asking about how do you feel about the use of orexin antagonists in PD patients who suffer from sleep maintenance issues?
Orexin or hypocretin is actually a neurotransmitter in the brain, which has a very important function in regulating sleep. Actually, I did and actually it's the cause of that narcolepsy. So those patients falling asleep, it turned out that they actually missed that peptide in the brain. It's very interesting. I did my PhD on that by coincidence. And that's 25 years ago that it was discovered, and we hoped, oh, maybe we can develop a pill that actually takes over that function. Well, those are very recently starting to become developed, but what sooner happened was that they could make pills that block this receptor. And actually, this is a relatively new generation of sleeping aids, sleeping pills. And basically, you make someone a little bit narcoleptic only at night, for example. In the context of Parkinson's disease, there's not that much experience with it yet, but they have some favorable properties if you compare it to the old-fashioned standard sleeping pills. It's not available in every country yet. But if it's available in some local, these are pretty interesting compounds.
So talking about sleeping pills, some of them actually are basically can make your symptoms worse. From what I understand.
Well, and a lot of those, let's say the standard sleeping pills also, if you look at the structure of sleep and how actually the sleep patterns actually look, you fall asleep, but they're not as nice as they should be, for example. So they do affect also a lot the structure of the so. On the other hand, some people still they can be useful.
And some others, of course, have addiction issues. So you can take them for a couple of weeks and then no one wants to prescribe them to you anymore.
Addiction is always a bit difficult word, of course, because one, you have tolerance, and actually you get withdrawal if you stop them. So it's very difficult for people to stop again. Not necessarily that they start roaming the streets to get more pills, but quick tolerance. So most of these kind of pills way best either very short term or only a couple of nights per week. And of course, taking into account the side effects, etc.
So Nancy has an interesting question. She says, how to know if you have sleep apnea if you live alone?
Very good question. Well, you don't automatically, even if you not sleep alone. That's not the case. Let's say if you have relevant sleep apnea, it translates into symptoms. And for example, if you were always waking up quite refreshed and you're not sleeping during the day, and over time you notice that you're starting waking up much less refreshed than you used to be, become more sleepy during the day, maybe wake up with a sore throat, a very dry mouth, for example, headache in the morning, there are signs that can point to possible sleep apnea.
So someone is asking about a drug that I've never heard of. It's called Gravol. I don't know if you've come across that name.
It's another one that is. Again, not the brand name used in the Netherlands, but that's it's an anti-nausea drug, and it's an antihistamine, and it's also used for allergies, etc. And antihistamine medication is very well known that a side effect is actually sleepiness.
So that person is really asking about, is there a limit? Is that something which you should be concerned about taking too much of?
Oh, yes. For sure, you can get it over the counter, but you can paracetamol as well. Yeah, can have side effects. Can have
So something to be
also
careful with.
for sure have nervous system effects as well. Yeah.
So still on the topic of sleep drugs or sleeping aids, Lisa is asking whether you can please discuss the effects of long-term use of prescription sleep medication. We were touching on that a few minutes ago, but actually...
Again, that sleep medication can mean a lot of things. So the classical sleeping pills, the benzodiazepines,
yes.
we know that longer term use can often lead to tolerance, less effect, but then also withdrawal when to stop, and side effects, etc. There are some other medication that also have effects on sleep that are, if there are no side effects, have less issues longer term. So, for example, certain antidepressant drugs can improve sleep quality as well. More and more, of course, well, as somnologists, we are a bit against on the, let's say, the indiscriminate use of sleeping pills if someone has insomnia, if you haven't tried, for example, the first-line treatment like sleep therapy. On the other hand, we know that in some cases the therapy doesn't work, other things have been done, and then if there is a well thought out choice to take these medications, I mean, of course they have effects, so it's not automatically they're all bad, but indiscriminate use is an issue, of course.
Yes. So someone anonymous is describing the situation where he or she is sleeping with his or her mouth open and it's getting a dry mouth. Is there anything that person can do? That's something you have come across as a symptom from your patients?
Yeah, it's in the same category as snoring. Not every snorer, of course, for example, has sleep apnea, so then it can be a bit of a cosmetic problem. Often it happens a bit of that there is actually some nasal passage problems, and actually that leads to mouth opening. Sometimes body position depending, etc. So it's a bit en vogue, people taping their mouths recently. Well, that's something that's not automatically advocating for, let's put it that way.
So Leslie is having very vivid dreams, but she says that they are not unpleasant, but very, very detailed. And she's asking whether this is PD or levodopa. I don't know whether levodopa can cause vivid dreams. I've never heard about that, but...
Yeah, well, and it can be both. It can also be something unrelated. So vivid, vivid dreams is, let's say, a phenomenon that we hear more often. It's not automatically abnormal, especially if they're not necessarily unpleasant. But no, it could actually be the levodopa as well. Yeah.
That's interesting. Anne is asking a question that I think will apply to many of us. She basically says, what is the best way to resume sleep after, for instance, waking up at 4 a.m.? Now, it happens to me quite a few times. And the last 2 hours of the night 3 hours tend to be more difficult.
Yeah. What is the best way? It's not that easy to answer. Often, what's not the best way is to stay in bed, start reading, or start ruminating, etc. More often in those cases, it's actually better to leave your bed for a little while. Don't write light or don't do something very active, but actually leave the bedroom, sit in the chair, dim light, and then only go to bed. Actually, that's often actually more effective. Yeah.
That's interesting. So Stella is basically making an assumption she would like you to validate or not. She basically says insomnia is surely expected when not doing much during the day. So do you think that low level of activity during the day might cause people to not sleep at night? Or very active days, on the contrary, could help them sleep better at night?
Yeah. It is in general a factor that can indeed play a role. And actually that's what I meant is is on those daytime naps. It's all about balance. So very often a general sleep therapist, where someone goes with insomnia, they say you should not sleep during the day because it takes away from the night. That's not automatically the case. If, for example, someone with Parkinson's disease, which spends a lot of energy, does a not too long nap in the middle of the day, and that helps actually to become more active in the afternoon and the evening, it can actually be very beneficial to your nocturnal sleep. So I'm not automatically saying that it's just always the result of being inactive, but yes, activity patterns during the day for sure have a reflection at night. Yeah.
So Mary, I think I can always answer that one for you, but I will still ask the question. Mary says, I have no problem falling asleep, but I wake up after a short time and can be awake for most of the night. She takes controlled release Cinemet, melatonin, magnesium citrate. What can I do to get decent sleep? I think from what she described, I guess she should see a somnologist like you.
Yeah.
Because if she doesn't sleep at all at night, this is a critical situation.
Yeah, exactly. That's that. And yeah, yeah.
Now, Itiozo is asking about Advil PM. I don't know whether that is what it's called in Holland. Advil PM.
The Advil, the painkiller, you mean? Oh no, Advil.
Probably.
Yeah, again, it's I mean the.
So half our audience is in the US, so you might just come across sometimes different names.
It's the combination again. Yeah. Again, yeah. The PM version. Yeah, I'm just looking at what all those brand names. Yeah, it's ibuprofen and the diphenhydramine, the antihistamine medication.
Yes.
Yeah.
Do you approve of using this as a sleeping aid?
If there's no side effects, it's the same a bit like taking melatonin every night.
Yes.
I come back to the fact that in general, you shouldn't need to take a tablet, a medication every night to fall asleep. Apparently, there's a reason. I'm not saying that this is in essence a bad solution, but it raises the question: what's the reason? And maybe there's some other solution that's more long term or not medical, or not medical.
So I think a big learning point listening to you today, actually, Sebastiaan, is that I have personally, before today, not considered reaching out to a sleep specialist because I had never really thought about it.
Yeah.
And from what you describe, I think that for anyone having serious issues with sleep, and many of us will be in that category, it's something we should consider. So that is my own reflection about this, and I might do that myself.
Yeah, and again, and don't get me wrong. Again, as I'm saying, if you're functioning properly, there are no side effects. You can afford it, etc. But on the other hand, yeah, if I would say to a person, okay, I'm going to prescribe you medication X for the rest of your life, other people say, well, do I really need that? Interestingly enough, with over-the-counter all kinds of medication, that cognition is not always the case. So yeah.
So there is someone here really mentioning a personal experience. He or she finds that microdoses of dissolvable MADOPA, so levodopa, dissolvable levodopa, helps him or her get back to sleep if awakened during the night.
Yeah.
And I had the pleasure of interviewing Michael Okun, who was also recommending the use of levodopa during the night. So this is something that actually you would support.
Yeah, for sure. And so there are different strategies. So sometimes the longer acting one before bedtime can help, but especially when waking up, indeed. And again, so that's why there's no one size fits all. But indeed, the fast acting disperse of levodopa can be very helpful in this context to actually fall back to sleep. Yeah.
This is actually my personal experience, and I find it particularly interesting that actually you do not always recognize that you're waking up because of your symptoms. You wake up and you don't necessarily realize I'm off. And I think that depending on the situations, in my case, controlled release or very small doses of levodopa help me regain, if you want, the ability to find the right position to sleep. So it doesn't make me sleep, it helps me to be more comfortable.
Yeah. No, so that's probably one mechanism. There could be some other mechanism, but that's a very good. It's a good point. And that sounds, it's a good example. If that's the more rational or maybe more fitting than taking all kinds of other medications. So that's it's a good one. Yeah.
So Nigel is asking about antidepressants and their impact on REM sleep.
Yeah.
He has come off citalopram, and his REM symptoms have improved. Does that ring a bell for you?
Yeah.
Makes sense?
Yeah. So yes, the most classes of antidepressant medication have a quite strong effect on REM sleep. They can sometimes suppress it in the beginning of the night, and then later in the night it comes actually back more.
Yes.
But also they can induce that muscle activity and actually can lead to that REM behavior disorder. So especially if there's a young person that gets RBD, that's weird. Then you always should also check for medication. And on the other hand, if someone with Parkinson's has that REM behavior disorder, you always check if they, for example, use these kind of medications, and actually reducing them or withdrawing them can help. Yeah.
So Alistair is just sharing his positive experience with cannabis. So we touched on that before. Thank you, Alistair, for sharing that. I have had positive experiences as well. I've mentioned some of the risks in my experience as well. So Leslie is asking about health technology. Now we spoke about the Apple Watch, and you were talking about the limitations, saying that for someone who has good sleep, it is more informative than for someone who might have very bad sleep. Now I'm using the Oura Ring, which is basically the same declination than the watch, and I see the same shortfalls that you mentioned about the watch as well. But is there any health technology you would recommend, short of going to the hospital? Is there anything out there that might be slightly more expensive that would be better suited?
Well, and the question, better suited for
measuring sleep quality and quantity.
No, not necessarily. Let's say in the consumer sphere, not necessarily. Actually, and again, to be very clear, I'm not against Apple Watches and other smartwatches, as long as someone recognizes some of the limitations. And for example, one way, the distinction between wake and sleep in general, so forget all the stages, etc., they start to do pretty okay, especially if it also is congruent with your own experience. And then if you find it actually stimulating, or seeing looking back, maybe looking at patterns. Hey, those days that I've been active more during the day, actually my sleep was a bit longer. I mean, if it results in these kind of nudges, then of course it's a good example of something is useful.
What I find particularly difficult to control, so to speak, is not only the number of hours you sleep, but the type of sleep you have. Because sometimes the device tells me that my deep sleep was 0.
Exactly. So that's one of the issues. So again,
what do you do about
example,
it?
if you have a step counter on your watch, that's very clear. It's a very easy number. You have so many thousand steps, and then you need to reach so many. And if you need, I have not enough steps, you know what to do. I need to walk. But what if it's, say, your percentage of N3 sleep is too low? There's nothing you can do about to influence it. And then actually these kind of technologies are maybe not the smartest.
Can be disruptive. I have a great question here from Boyton Boy. He basically is asking whether there is a preferable body position to sleep that would help you not only fall asleep easier, but to get a good quality of night sleep.
I want to be very careful to do that, because, for example, if you have sleep apnea, very often it's worse when you're sleeping on your back, as an example. But on the other hand, if you don't have sleep apnea and it's the most comfortable position, there's nothing against it. So I tend to stay away saying that there is a specific position. No.
So your experience is that you have seen people being successful with various positions.
Yes. But that doesn't take away that, for example, we sometimes, again, the sleep apnea is an example. We sometimes actually try to prevent certain sleeping position, but there's a specific reason for that.
Erin is asking a question I think that you have already answered about how much microdose of Cinemet in the middle of the night, ? Swallow under the tongue.
How much? Again, that's a very typical thing. That is really something up to the neurologist, and depends on a lot of factors.
And it can vary over time. You might just be okay with a 25
and it depends
milligram.
on the state. It depends on the phase of the Parkinson's. It depends on the other dopaminergic medication that's being used. There's different.
So someone anonymous is asking about diet. banana and milk, for instance. Is
Yeah.
there like any grandmother's recipes that you think
Yeah,
has
I don't
some
know.
wisdom?
No. Yeah. Yeah, in certain foods, there are some substances that, and so like in the sleeping teas, etc. So and supplements that have can have some mild positive effects
Yes.
on sleep. There are some other yeah, so there is like tryptophan in there. There's some other foods like heavy fatty foods before sleep can actually disrupt it. Alcohol can of course disrupt sleep,
Not
etc.
enough.
So yes, there is
Not enough alcohol disrupts, and too much alcohol.
yeah.
So Paul is asking about neurology issues, actually.
Yeah.
And he's asking what proportion of sleep disturbances that you see in Parkinson's are due to neurology issues?
Yeah. Forgive me that I don't know the exact percentage.
No, but is it a lot or?
Oh yeah. Oh, and again, that's an interesting. Well, a couple of weeks ago, actually, I had on the Parkinson sleep clinic someone was referred by the neurologist by severe sleep disruption and insomnia. Please diagnostics. And they say, yeah, I've got such urge incontinence. They had to get out of bed 7 times per night. Yeah, I mean, hi, and didn't see had not seen a neurologist yet. So. I mean, just as an example, yeah, there are bladder, urinary issues, etc., that typically occur at night. Because again, there's more urine production at night, etc. That can be very, very important. Yeah, I don't know.
So,
I have a certain percentage maybe in my practice, but that's a very selective kind of issue. But it's a good example that sometimes a neurologist in PD knows that there are urgency and incontinence issues during the day. And then they send to a urologist, but they should also ask what's happening at night. Yeah.
Thank you very much, Sebastiaan. I think we will leave it at that. I think that you answered 41 questions, so thank you very much. We left a few open, but I think we answered a lot of the most important questions that were interesting for the most people listening to us today. I'm very appreciative of your time. It's slightly later where you are in Holland, so thank you very much for dedicating your evening to us.
No problem.
And thank you also for communicating to us. I think what is the main message is that if someone has very serious sleeping issues and has experimented with everything that he or she could think of as safely as possible, reaching out to a sleep specialist, a somnologist, is very important.
Yeah,
it could be you, it could be anyone.
Mentioning it to your Parkinson's disease caregivers, actually PD nurses are a godsend also in the sleep field of detecting it, and then make a plan. And it could maybe be that already they can solve it, but at least know that they should look at it, and very often something can be done about it. Yeah.
Thank you very much. Thank you very much. Now, to our audience as well, thank you very much for joining us tonight. We were quite a big number of people on the call. I'm very appreciative of your support. So that you know, the next session will be on the 14th of April. We will have the pleasure of listening to Alberto Espe, who spoke to us before. And Alberto will be talking to us about a new Parkinson's test. And the title of the talk will be Hope or Hype. So the invitations will be sent probably within a week or 10 days, but you can already pencil it in your diary, 7:30 p.m. London time on the 14th of April, Alberto Espe on the new Parkinson's test. Sebastiaan, thank you very much. To our audience as well, thank you very much. I will stop the recording here. Speak to you soon.
Okay, bye-bye.
Bye.